and I'm going to introduce you to our moderator for today. So Dr. Patchawala will be moderating the session. She is an associate professor of medicine at Rutgers, New Jersey Medical School and is the program director of the Pulmonary and Critical Care Fellowship Program. Dr. Patchawala is also the medical director of the Lattimore practice here at the Global Tuberculosis Institute. Dr. Patchawala also attends at the Medical Intensive Care Unit, as well as the Pulmonary and TB Consult Services at University Hospital here in Newark. So Dr. Patchawala, I will pass it over to you.
Hi, thank you so much, Olivia, and thank you to all of the organizers of this, what looks to be an amazing conference. So I would like to officially welcome you all to the 2021 New York City World TB Day webinar, Back to the Future, Threats and Opportunities for TB Prevention and Control. Here at GTBI, we are excited to once again partner with New York City for this annual event. There are over 300 people registered for the conference from all over the globe, and what brings us all together is our interest in tuberculosis. While we cannot be together physically this year, I'm sure that our speakers will connect and engage us with their words. So with that, I would like to introduce our first speaker, Dr. Akriti Pandita. So Dr. Pandita is an assistant professor of medicine in the Division of Infectious Diseases at University of Colorado. In addition to her clinical practice, her research is focused on tuberculosis, COVID-19, and healthcare disparities. She is also a member of We Are TB, a TB survivors group. Dr. Pandita is a TB survivor herself who advocates for patient-centric care. And I think that no TB conference in 2021 is complete without the perspective of a patient. So welcome, please welcome Dr. Pandita.
Thank you so much, Amy, for the introduction. And I will begin. Are you able to see my screen?
Yes, we can. Looks great.
All right. So I'm going to talk about patient perspective in TB and patient experience, and I have no disclosures. I'll start off the objectives of this talks overall. The way that I have put this together is I'll start off with my own experience as a TB patient. I'll then talk about the various barriers to patient care. And we'll talk a little bit more about patient-centric care. What exactly does that mean? And how can we practically implement that in our day-to-day practice? The book on the right side is a very great book by Dr. Ofri, who writes quite a bit about patient experiences in healthcare. And I think it demonstrates this so well that what we do as doctors doesn't always translate to the other side, and what we say, the patients may not hear the same thing and vice versa. This is just to, before I go ahead, I just want to point out that my experiences as a TB patient were by no means any unique. I think I've talked with so many survivors over the years, and I feel like my experiences were in fact better. So my intention overall is not to point fingers at anyone, but it's just to highlight certain themes that are very common in all these stories, and how could we use that information to improve patient care. This is just a painting which I really liked in the Union office. The gentleman on the left side, of course, has TB, and the one on the right, this is the kind of experience that we are looking forward to bring to the TB care. So this is me 7 years ago. I was a fresh second-year resident, and second year is when you begin to have a lot of responsibilities, and you are very much excited to take on this new role and be a little bit more independent. So that's when I started with low back pain, and in the beginning it was not bad at all, but subsequently it worsened and came to the point that during these rounds I would just freeze in the middle of the rounds because of painful back spasm, or wake up in the middle of the night with spasms. So it was not at all uncommon for me, and that happened gradually over a period of months. I saw many providers and had many MRIs, and this is my initial MRI, which we got in one of the ER visits. And as you can see on the left side, you see a little bit of a blip there. And this is what, it's a little bit non-specific in the radiology world at what they call as a humoral node, which basically means that the intervertebral disc kind of protrudes and collapses a little bit into the vertebral body. And it's not very specific. Most of the patients may not have symptoms. Some patients may have some pain. It may happen in some conditions with infections or cancer. So it's a very non-specific entity. And that's what I had in the beginning. So I discussed it with my primary care, and we thought that this is all musculoskeletal back pain. So I went through a lot of physical therapy, and that didn't do much, all the conservative management that most patients with back pain go through. And despite that, I progressed. So the next step really was to see consultants. I ended up seeing a PM&R specialist who was of the opinion that I have something called pelvic floor dysfunction, which is a kind of condition that happens generally in women who had multiple childbirths, which was not my case. I then went on to see a rheumatologist who thought that I had ankylosing spondylitis, and I was on steroids for a while. And then I sought another opinion, and we thought that, okay, I could have seronegative arthropathy, and Plaquenil was added to my regimen. So for months I was on steroids and Plaquenil, which was most of a empirical treatment for a rheumatological condition. But despite that, I took time off from work. I underwent pelvic PT, which I don't know how many of you are familiar, but it's not very comfortable treatment either. So it was at that point, I think, and I was lucky in the sense that I had a medical background, and my dad was a physician as well. We put our hats together, the physician hats together, and we thought, hey, we haven't really thought about TB. Why don't we get a quantiferon test? So that's when we caught TB, because the quantiferon test was positive. I went to see an ID physician I trained with, and I had faith in him, and he suggested going for a biopsy. But unfortunately, by the time the biopsy was scheduled too far out, and by that time I could not walk, I had fevers and all the typical manifestations. So 1 year after my initial symptom onset, I was formally diagnosed with TB. But the journey didn't end there. I thought I was relieved at that time, thinking that, hey, I have an answer and it's not in my head. So I was started on the right regimen, and I was on daily regimen for 2 weeks, was starting to feel better and was able to walk. But then my regimen was changed to thrice weekly regimen, and that's where I started feeling worse again. In the next few days, I was admitted to the hospital. My regimen was switched back to daily again. I did better, was discharged, switched back to intermittent regimen again, did worse again, was readmitted again. And at that point, I was flown to Boston to see this ID physician who had much more experience with TB. And as you can see, these are my scans over a period of time, show clear worsening of the disease. And I got started on this kind of an atypical regimen with some of the drugs that are generally given in drug-resistant TB, even though I had sensitive TB, all in the hopes that my disease progression would slow down, because at that point I had neurological symptoms and I was advised surgery that involves placing of hardware. So it was very complicated. And my drug levels were also very low, the rifampin levels, undetectable on daily. So probably that also contributed to this whole situation. So the good thing is I eventually came out of it. The whole experience was not good because it took another year to recover from it. And this was my new normal for about 1.5 years, where I was totally dependent on my family for day-to-day, even the basic activities. And my father had to leave his clinical practice in India and be with me for a year because I had no kind of support in the US. But the important thing to remember is I recovered. And here I'll kind of transition to the next section of my talk, which is going to be about different kind of barriers to care in TB. Before I go on to that, I don't know how many of you are familiar with Max Fletcher. He wrote this novel, Scarred Hearts, when he himself had TB. He was a medical student in training and had back pain for some time, labeled as rheumatism, which I feel is a blanket term at that time for the musculoskeletal back pain. Eventually was diagnosed with TB after a year or more, I think years of having back pain. And the treatment at that time really was immobilization and iron cast, full body iron cast for years until hoping that the disease would get better. And it was not at all uncommon to wheel these patients to the beach or other places just sometimes. So the reason I'm bringing this up is because the delayed diagnosis is a common theme with all patients with TB. And it's interesting that in 1928, that was the pattern, and it still exists to be a pattern even right now. This is a study, it's a small study, but which was done in UK of all the patients who had Pott's disease. And the reason I'm putting this here is the interesting observation that they did, that the average delay in diagnosis was 11 months in these patients. An average patient sought 3 or more referrals before a diagnosis was made. So what exactly are these barriers to care? The way I like to see it is the way the disease is, which is we have latent TB and we have active TB. In the same way, the barriers are also could be understood in that way. And the central fulcrum point is the diagnosis. So there are various things that happen before a patient gets the diagnosis and is seen by TB officers in the TB clinic. And there are things that happen after the diagnosis, after they're started on treatment, and those are the active barriers. The latent barriers are really the experiences brought on by the delayed diagnosis, which is in most cases, seeing multiple providers, hearing multiple diagnoses, having multiple visits, getting started on multiple kind of treatments, the lack of experience in general with TB, mostly not so much relevant for the TB providers, but the ones before that, the journey before. So there, and this is more relevant in, I think, in developed countries. The communication piece, which is common theme for healthcare in general. Our systems are so disjointed. One person doesn't talk to another. The EMRs are so different. So all these factors lead to a general skepticism in healthcare, a mistrust in providers, which is what a patient, when he comes at your door, this is the kind of baggage that they bring with them. And that's when they establish care at the TB clinic, is when active barriers start to come in, which are, this is a study, again, it's a qualitative study that looked at all the various barriers in treatment adherence for the patients. And of course, this is what we most talked about, and in general, the unsupportive antagonistic interactions with TB providers, or the financial toll that comes with TB treatment, especially for low-income patients, patient compliance, high bill burden. So that's more relevant after when they get started on TB treatment. So we keep talking about the patient-centric care. What exactly is that? I like this slide because it just makes this point clear that no matter what we do, which is working on the implementation piece, talking about the social factors, political will, all these pieces cannot be glued together without this core element of patient-centric care. So the question is, what exactly is patient-centric care? Because it sounds so good, but what is that? And the way I see it, it's one size doesn't fit all. It's interesting if you look up, if you just search on Goodreads, there are so many books with the same title coming on from so many different industries, like labor to church to so many different industries. And I think world in general is moving towards one size doesn't fit all approach, which is more customized, and it's coming on to medical field as well. The question is, has this been really incorporated in the TB world yet? So WHO has some excellent guidelines on patient-centered care, and some of the things I'm sure a lot of you are familiar with, which includes patient counseling, communication using modern tech tools. We need to have a nutrition support, social support, having the thing that I really like about this one is the focus. There is a drift in the focus from facility-based DOT to more community or home-based DOT, and WHO has recognized this. It's a crucial element, and all these things are great and excellent ways to make the patient care centric. But a lot of times, and this comes up so many times when I discuss with my colleagues in the TB clinics, that how many times is it really practical to do this when at a grassroots level, especially in resource-poor countries? And that's where I think, yes, we should continue to work on all these things. But the core of the problem, which I feel needs a little bit more attention, is that it's the recognition that the TB population, the patients with TB, it's a unique population. There is no other disease, even infectious disease, where the care, the focus, once you're diagnosed with a disease, the focus is not so much on the sick patient, but the focus is on those around them. And I think that's where we need to do some work. And that can be established at the outset when they begin to establish care at the TB clinics. Really starting off with basic things like acknowledging that the process is awkward, the process is a little bit strange, but why is that? And really acknowledging that the beginning is going to be hard, but we'll get through it. And why is it so hard? Providing them with materials on their rights as patients, things like that. So I think if we are transparent at the outset, we break the ice when it comes to taking care of all these latent barriers, and then the active barriers are also taken care of in that sense. This is another book that I really like, is by James Merlino, who was the guru of building patient experience in Cleveland Clinic. And he has excellent ideas about how to improve patient experience and how he ended up doing that at Cleveland Clinic. But the one thing that he talked about, which is the beginning of all this, is patient first as true north. And I think the change, there needs to be a certain shift in consciousness and in awareness overall, that how can we be more mindful of the process and building trust, because that's how the patients are going to be adherent to their treatment if we build that trust from the outset. Using family as a force for good, if of course the patient is okay with it. And a lot of patients who have TB, they have the cultural background where they really trust their families, and I think that could be used as a very in a very beneficial way to improving care of these patients. And of course, limitation of guidelines, seeking out expertise when needed. And I think that's one way my practice changed. I seek out expertise all the time when I feel I need second opinion. And really the future is personalized care in TB. And I'm going to skip this slide because Dr. Pai is going to talk about TB and COVID, and really excited about that talk. So I just want to end up by really showing this thing. In case you're wondering, on the left side is my plate-like vertebra, which it's really on resolution. That's how my spine looks now. And this pictures on the right are a trip I took right after I recovered, which it's a long fort in India in Jaipur, and that's how they're on the right, walking all the way up there. I just want to end up by saying that the patient care in TB, I know the goal is really to end TB, but the means are as important as the end. So the goal, I think, should be modified to really reforming the means to end TB and, of course, to end TB. Thank you for having me here. And I'll conclude.
Dr. Pandita, thank you so much. Very powerful, your narrative, and I think both from a physician's point of view as well as a survivor's point of view, there's just so much for us to learn. And I think one of the things that struck me the most was, some of the things that just sound like they should be, basic, good, heartfelt communication tools when we're meeting patients for the first time. One thing you said about just the acknowledgement of what you've been through before, that it's taken you a year plus to get to this point. Did you have any experiences where you felt like somebody did it great and we could somehow figure out how to replicate that? Or more?
Yeah, as my experience as a patient, I don't think I think the things really changed for me when when I saw my ID physician in Boston. I think she was cognizant of the fact, and I think because she had tremendous experience in taking care of patients with POTS disease in Africa, and I think she acknowledged that, and that made a lot of difference to my care overall. I think this acknowledgement part is also one of my mentors during fellowship. She was the ID. She was a physician in the Rhode Island Department of Health. I think I've seen her when she talks to her patients with TB, and most of them, they don't even speak English. I think she's the one who really brought this to my attention, that, hey, acknowledging this at the outset. And then when I thought about it, looking back in my experience, who did that with me? And I think nobody except that one physician. And that's probably because most of the people before the diagnosis had never seen anyone with TB. So they didn't know. And I think that's where the problem is. The problem is once they are in your care, they're generally good. And I know, because I have so many colleagues who are work in TB clinics, and they're amazing. But the thing that disturbs me is that what happens before they arrive at your door. And that's where I think a lot of work needs to be done.
Yeah, thank you so much. I think there are a number of questions in the chat as well as in the Q&A, more specifically about your case in particular, and lessons, that you can share for providers, especially around patient education and things like that. I think we will have time at the end of all the presentations, and so maybe we can come back to some of these as well. But I want to thank you again for sharing your story. I think the more that we do this, hopefully the more we will learn, and the better we will be. So we are moving on to our next speaker, Dr. Berzinski, who I think most of you know very well. Dr. Berzinski is the Assistant Commissioner at the New York City Department of Health and Mental Hygiene, Bureau of TB Control. He received his MD degree from the University of Louisville School of Medicine and his MPH from the Harvard Public Health School. He trained in internal medicine at St. Elizabeth's Hospital and infectious diseases at Brown University. He's board certified in internal medicine and infectious diseases. Dr. Berzinski has worked at the Bureau of TB Control since 1995 and has served as the Assistant Commissioner since 2013. And welcome to your show, Dr. Berzinski, and please tell us about TB in New York City.
Great. Thanks so much, and welcome everybody. Thanks for joining us today on World TB Day 2021. Thanks, Elvi, for helping with the slides there. I really want to thank the first speaker there. It's so important when people who have gone through the experience stand up and talk and share with us their experience. We learned so much from that. And I want to thank Kate O'Brien and her organization. It's really so important. Keep that going. It moves us. It reminds us why we're in this work. And we always learn something when we hear these talks from people who have gone through this experience before. So thank you very much. That was really, really great. Before I start my talk today, I just want to acknowledge the terrible events that happened in Atlanta a couple of days ago, and the rise in anti-Asian hate crimes across the United States. I just want to say that we stand in solidarity with our Asian patients and Asian staff, and we really have to continue in public health to fight against racism and white supremacy. So that's a message from all of us in New York City. Next slide, please, Elvie. Okay, so we have some great talks today. Dr. Patawala is going to speak. My friend, Dr. Jason Stout, will speak. And of course, Dr. Pai always gives great talks. So I think everything you're going to hear is going to be fantastic today. What I'm going to talk about a little bit is the epidemiology of TB in New York City over the last year, the impact of COVID-19 on our patients and how it affected our program, and then just give you a few other brief updates in TB. So next slide. So I'm going to start with the epidemiology of TB in New York City. So this figure shows our rates in New York City since 1984. In 2020, we saw a 20% decline in TB case reports. So this was just an incredibly unexpected for me, and an incredible reduction. So last year we had 445 cases for a 20% decline, a rate of 5.4 per 100,000. We're not really sure why we had this large decline. I think Dr. Pai may touch on this in his talk, because this has been seen really across the United States and in global TB, and it could be because there's decreased reporting. That's one possibility. There might be some effect of people staying away from each other and wearing masks. It could be less people seeking healthcare. There's lots of reasons. We really hope to understand this better, and we're thinking about it a lot right now. So next slide, please. This slide shows TB cases and rates in New York City by birth in the United States. The lighter blue represents cases born outside of the United States, and the darker blue represents cases born in the United States. The majority of TB cases in New York City continues to be in those individuals who were born outside of the United States. On the left of this slide, you will see TB cases by gender in New York City in 2020. We continue to see that most cases of TB in New York City are in males. On the right-hand side of this slide, this graphic depicts 2020 TB rates in age group by age group. 57% of TB cases in New York City in 2020 occurred among people who were 45 years or older. This figure shows TB rates by race and ethnicity among patients born in the US. Non-Hispanic Black New Yorkers represented by the yellow line have had the highest TB rates in recent years. You'll also see that the TB rate in the group declined sharply between 2019 and 2020. This slide shows country of birth among the TB cases in New York City in 2020. On the left, you will see that the highest burden of TB cases in New York City was among those born in China, followed by US born and Bangladesh. On the right, we are showing countries of birth with the highest incident per 100,000. Sierra Leone, Burma, Nepal represented relatively low numbers of TB cases, but still had a high incidence per 100,000. And Bangladesh is on both lists, indicating that there is both a high TB burden and a high TB rate in the community. This slide shows TB rate by New York City neighborhood in 2020. We continue to see some of the same neighborhoods with the highest TB rates in 2020. These include West Queens, Flushing, Hunts Point, Mott Haven in the Bronx, and Sunset Park in Brooklyn. Here we show multi-drug resistance among New York City TB cases from 1992 to 2020. Fortunately, those numbers look like they continue to decrease. They've decreased drastically since the beginning of the 1990s, but we continue to see a handful of MDR cases annually and occasionally a patient with XDR TB. In 2020, there were 5 MDR cases and 1 extensively drug-resistant case. I will now share with you some data on how COVID-19 directly affected our patients with TB disease in the city. We are very much interested in trying to understand this better. We want to make sure that we're doing everything we can for our patients in the context of this virus. Next. So first, I will share some information about patients diagnosed with TB who had a positive COVID-19 test result. We use the Department of Health registry to match cases of TB with a confirmed or probable COVID-19 diagnosis. A probable COVID case is defined as a positive antigen test, a person with symptoms exposed to a confirmed case, or a person who died and the cause of death is COVID-19, or a positive molecular test for COVID-19. Over the last year, 71 patients with TB disease were co-diagnosed with COVID-19. This slide shows each of the 71 patients' date of TB diagnosis in blue and the date of their positive COVID test result in yellow. The blue lines show that TB was diagnosed first, followed by COVID. The yellow lines show cases where COVID was diagnosed first and then later TB. Most patients were diagnosed with TB before receiving a positive COVID-19 test result. And of course, COVID-19 testing became available in New York City in March of 2020. Now we turn to the demographic characteristics of the patients with TB disease and those with TB and COVID. A significantly higher proportion of patients with TB-COVID co-infection had diabetes. And unfortunately, not surprisingly, a significantly higher proportion of TB-COVID patients died in comparison to TB-only patients. Next slide, yeah. In this figure, we show the difference between TB-only patients and patients with TB and COVID-19 by age group. The blue represents people who have died. You'll see there was a higher proportion of mortality among TB-COVID patients who were older. We are quite concerned about this higher proportion of death among patients with TB and COVID-19. We're continuing to evaluate this data to try to understand the impact of COVID-19 on our TB control program. So in addition to the impact of COVID on our patients over the last year, of course, the epidemic has had a great impact on our program practices. Like so many of you, our programs have faced many challenges and our staff have been pulled into doing COVID work. We've tried to maintain our core essential services. Despite all the challenges, I think we've done a really good job of continuing to provide the core services that our patients need. I'm going to highlight some of these innovative solutions we used in order to continue providing the services. In March of last year, we made a quick decision to close 3 of our 4 TB clinics in the city. We felt many patients, of course, did not want to travel to come into our clinics, and it was difficult for our staff to go to work too, and we wanted to minimize direct patient interaction as much as possible to prevent the potential spread of COVID. Since March of last year, we have reopened 2 of our clinics, so we're not at full speed yet, but we're getting there. At the very beginning, we only saw appointments that were really priority, patients who had confirmed or probable TB disease and recent contacts who needed an in-person evaluation in the clinic. But we did move to implement telehealth. We had just started a program of telehealth a few months before March of 2020. So from that pilot, we ramped it up really quick, and we were able to offer telehealth services through the phone or video evaluations for the majority of our patients. We also worked really hard. We're able to provide medications through our clinics to our patients. And so we were able to do that either through the mail or by delivering directly medications to patients' doorsteps. Okay, next. This figure illustrates how our clinical services changed in the context of COVID. The yellow line represents in-person clinic visits. They dropped off dramatically by the end of March 2020, when 3 of our clinics closed. At the same time, this figure shows that our telehealth visits increased when the clinics closed, and we shifted to phone and video evaluations. This figure also shows how telehealth slowly decreased later in 2020, and in-person began to increase as the 2 of our clinics reopened in July and August. We continue to offer telehealth as a convenient option for many of our patients who may not be able to come into the clinic for every visit. This slide shows our staff who continue to work to provide excellent care options to patients. And this was really, I especially want to credit our staff who work at the Fort Greene Clinic. Our Fort Greene Clinic is in Brooklyn. It's got good subway access. And we kept that clinic open through the scariest of times. And our staff really did a great job of providing service. They were brave. They showed great care for the patients that really needed it. And I'm really proud of the fact that we were able to do that. The other ways we adjusted our clinical operations over the year included conducting home visits on a case-by-case basis as needed. And as I mentioned earlier, we either mailed medications or hand-delivered medications to patients' homes as they needed. This picture on the slide shows a wonderful team of our staff during a home visit. Regarding case management, we substituted in-person activities to perform most of the work remotely. Patient interviews were conducted over the phone. We used to go for inpatient initial interviews, but of course we had to change that. So they were all conducted over the phone. We changed all of our directly observed therapy to video DOT in almost every case. Home assessments, home visits to look for contacts, to test contacts, all of that had to be suspended, and we hope to be able to restart that soon. Our program has scaled up some activities since last spring, for example, reopening clinics, but each step in the scale-up process has involved a great deal of discussion on how and when to do that and how to do it safely. It's really, we'd like to scale up even more at this point, but so many of our staff continue to work full-time on the city's COVID response that it's really not practical at this point. Over 50% of our staff have been directly involved in the COVID response at some point over the last year, and many of them continue to work on the COVID response full time. Next. We found it critical to support our staff emotionally over the last year. It was hard to work remotely, and many people reported that they just felt disconnected from their colleagues. So we did hold regular Bureau town halls to keep staff updated on program activities, the state of the pandemic, and most recently, the science behind the COVID-19 vaccine. We also had a weekly Zoom call on Fridays called Touch Base It's Friday, to give staff an informal opportunity to touch base and support each other. We've also continued to hold our Bureau-wide events, but shifted almost everything to a virtual platform. We've also tried our best to stay connected to our community providers over the past year through virtual outreach events, grand rounds, medical talks, case conferences. We're in the process of finalizing Ltbi public health detailing kit, which is featured on the left-hand side of this slide. The detailing kit will include a number of materials to support providers for an Ltbi risk assessment, screening, and reporting. These materials include an Ltbi treatment and tracking card, a billing guide, an Ltbi communications guide, and a TB 101 fact sheet. And we've also finished our new edition of the TB program manual, which is featured on the right side. The last version of this came out in 2008. So we're really happy to have completed the 5th edition. And I think a lot of you will be able to see it soon. It has updates on new LTBI treatment, new MDR treatment, and many other updates. It also includes more information on our programmatic and public health practices. We're very pleased that we're able to share this with our staff now and likely the general public very soon. So next slide. So I just wanted to give a brief update on some good news in the TB community. I imagine Dr. Stout will mention this in his talk because it has affected his work and he's been involved with it too. But this is some really good news that I think everybody will hear a lot more about very soon. So next slide. And this was the news from Study 31 out of the Tuberculosis Trials Consortium, which both Jason and I participate in. So this was a very large phase 3 open label randomized controlled clinical trial, the largest one ever conducted through the CDC. And it was really a landmark TB trial. The preliminary results were presented at the Union Conference this fall. And hopefully the results of the study will be published soon. So next slide. This was, of course, an international multi-center site study, and it was an evaluation of a 4-month regimen of high-dose rifapentine, isoniazid, pyrazinamide, and moxifloxacin. This was, of course, compared to the standard treatment. And the findings were that the results showed that the findings of the new 4-month regimen were non-inferior to the 6-month regimen. And the 4-month regimen was safe and well tolerated. So this was really exciting news that we are likely going to have a new shorter regimen to be able to offer our patients. Next slide. The implications for our program, of course, this would be a big change if we could offer our patients a 4-month regimen. This was the first successful short course regimen for drug susceptible TB in almost 40 years. We're just looking for those results to be published, and then hopefully we will be able to provide this option for our patients. So this is a beautiful painting that was done by one of our colleagues and a TB survivor, Dr. Sneha Maru. She painted this beautiful painting titled Breathe, and really meant a lot to all of us. She painted this at the end of her treatment as a way to say thank you. So I want to say to all of you and to our staff, thank you for being resilient. It's been a very, very tough year, but I think we did a great job. We've continued to provide the core services through our Bureau of TB Control that our patients need. And we provided a great service in all our contributions to the COVID-19 response in addition. So thank you. I think that's it from me.
Wonderful. Thank you. Thank you so much. There are a few questions coming in through the chat, and I think, Olivia, correct me if I'm wrong, but I think we have a few minutes to go through some questions. Yes. Okay, so Dr. Berzinski, there's a question about whether you could speak a little bit more about latent TB care in the 2 clinics that are open.
Latent TB care. So we do have 3 clinics open right now. We have 2 open on any one day, but we have 3 different clinics open. We are providing evaluations for contacts, and contacts who need treatment, we provide the treatment. So because we have less appointments available, less staff working in the clinics, we have not been evaluating as many patients for latent TB infection who are not contacts, but contacts are getting the full services.
Dr. Pai, do you want to unmute and ask your question? I think it's a great question.
Yes, given the co-infection of TB and COVID that you showed, Joe, which is very concerning, and the high mortality, does New York City need to give priority to people with TB for the COVID vaccinations, or is your vaccination progressing at such a good rate that eventually everybody will be covered in the next month or 2, according to President Biden?
It's a great question, and I'm very happy to say that we were given permission just a week or 2 ago, so that all of our patients with TB in New York City are eligible for the vaccine, and we've been able to provide it through our clinics. We ask our patients now in our clinics, would you like the vaccine? We can take you downstairs and you can get it. So it's great. We're very happy to do that. I worked in the clinic on Wednesday, and I had 3 patients that got the vaccine on Wednesday. So it was great.
This is outstanding. And I must say, I'm not at all hearing any advocacy from the TB community that folks with TB should get prioritized for COVID vaccination, in part because most low and middle income countries have nothing happening in terms of COVID vaccination. But where there is COVID vaccination available, like South Africa or India, should people with TB be prioritized is something we should all be thinking about. And your data are exactly what we need to show that the excess mortality is very worrying, and therefore we should push them up on the priority, even if they're younger in terms of age.
Yeah, I agree. Thank you for that comment. I'm very glad we were able to do that.
That's amazing. I think that giving people COVID vaccines is one of the most satisfying things to do these days. There was another question about the telehealth platform that you're using in your clinics.
Oh, okay. So we use FaceTime. If we have, most of our staff have Apple phones, and if the patients have Apple phones, we can use FaceTime. We're also using Google Meet, which is something that there's an app for, and you don't need to have an Apple phone. So we're using both of those platforms right now. They've been approved by our IT division that they have sufficient security measures, and they're actually fairly easy to use. The great majority of our patients figure out how to use the technology. And then in our clinics, I would say our doctors are probably the slowest to learn how to do it, but we have a lot of tech savvy people in the clinics that can help us set up the appointments. And so, I guess the hardest part is getting the schedule, but if you both, the clinician and the patient have a set time and they agree to that time, it works out really well. It's been very successful for us.
I think maybe we'll do one more and then we'll have a break. There's a question actually in the Q&A about whether you have more information or are planning, I guess, to look at the impact of the interruption of normal contact tracing that the COVID-19 epidemic has caused on TB, on incident TB cases.
Yeah, we absolutely do, because it's a real phenomenon. We've seen less contacts this year. Our numbers for percentages for evaluation and initiating treatment are down. We're not going into homes to ask for more contacts or test contacts in homes. So there's definitely a potential impact, and we're going to evaluate it. It's gonna, I think it's gonna be a long-term project. I imagine we'll find something, but that's all I know right now. We'll look at it and hopefully come to some conclusion.
Well, again, thank you for both informative and hopeful talk. I think that's really important these days to continue to have a bright light in everything that we share. I think it is time for break, which is another bright light. So Olivia, 10-minute break. We'll be back at 2:05.
Thanks, Dr. Patrawala. Yeah, that's right. We'll be back at 2:05 for the next presentation. Hi, Dr. Patchawala. I think we can probably get started whenever you and Dr. Stout are ready.
Dr. Stout, are you ready?
I think so. Let me see if I can share my screen here and turn on the video thing. There we go.
I will introduce you. So welcome back from break. Our next speaker is Dr. Stout, who is a professor of medicine in the Division of Infectious Diseases and International Health at Duke University. He serves as the medical director for the North Carolina Tuberculosis Control Program and a TB clinician for Wake County. In addition to maintaining an active clinical practice, Dr. Stout's research interests focus on the natural history, epidemiology, and clinical trials of TB and other mycobacterial diseases. He currently serves as the co-chair of the Tuberculosis Trials Consortium Phase 2 protocol team. Welcome.
Great. Well, thank you so much. And thank you very much to Joe and to the organizers for providing this opportunity to talk to you. Of course, what you didn't mention is that I'm an old Jersey boy, even though I live in North Carolina now, and I went to medical school in upstate New York. So this is like a virtual homecoming for me, so I much appreciate it. So in terms of disclosures, the key thing to disclose is that the study we're going to be discussing is the development of that study has been funded by a contract through the Centers for Disease Control and Prevention. I will be discussing off-label use of several drugs to treat drug-susceptible TB, but I don't have any pharma conflicts. Okay, so to put this all in context, I think it's important to understand, so how do we treat TB? And everybody on this call knows how we treat TB. So for drug-sensitive TB, we have this intensive phase of 4 drugs, which for an average size patient, or what used to be an average size patient, is about 9 or 10 pills a day. They're not small pills and they're not very pleasant to take. And then after that first 8 weeks, you go to 2 pills or 2 kinds of pills for another 16 weeks or 26 weeks. For multi-drug resistant TB, it's a different ballgame. Historically, it would be 18 to 24 months of treatment. Newer regimens are down to 9 months, but it's 9 months of a lot of different poisons, basically, that you would have to ingest. So it's really not ideal. And if you look at the drugs used for multi-drug resistant TB, it's quite a panoply. So the fluoroquinolones are commonly used, and those are generally well tolerated. But as you go down the list, you rack up a lot of toxicities. So it used to be said that the folks outside the sanatorium would sort of stagger around because of the balance of the vestibular toxicity from streptomycin. The injectables like amikacin have a lot of potential for toxicity, especially when used over the long term. Things like cycloserine, which one of my former residents used to like to say that when he was working in Nepal, he could always tell who the patients were who were taking cycloserine because they would take their doses and then they would run off screaming into the jungle. So it's not a well-tolerated medicine. Ethionamide, which is just horribly tolerated in terms of GI toxicity, and it goes on and on and on. So a lot of unpleasant medicines that we're giving to people. And then think a little bit about this in the context of how do we treat HIV. And HIV treatment in the modern era, it's not this sort of one-size-fits-all thing that we do in TB. It's very much taking into consideration the individual patient, their comorbidities, thinking about drug interactions, thinking about previous regimens. There's a lot of options. And this, of course, has evolved quite rapidly in the scheme of things. Because if you look at 3 decades of HIV, we went from no treatments to treatments that involved multiple pills taken at different times of day, which with high pill burden. But over time, the pills became more potent. The pill burden came down. Mortality increased dramatically. And over time, we've gotten to most first-line regimens are a single pill. So this little sample pill case is illustrative of some of the single pill options. So this is 1 pill once a day for treatment of HIV. It's quite remarkable to think how far we've come. And an important thing to consider when thinking about that is the costs of HIV treatment over time and the impact of generic competition. So originally, HIV treatments were very, very expensive and were thought to be out of the reach, particularly of folks in the developing world. But over time, generic competition has really changed that dramatically to a point where treatment for HIV in many places is something like $1 a day for effective regimens. And this is a valuable lesson when we think about TB. So TB is just some of my favorite 90s paraphernalia, but are we stuck in the 90s for tuberculosis? So like the late 90s of HIV therapy, we have a regimen to treat TB that is quite effective for drug-susceptible disease. But the problem is it's clunky with a large pill burden, and the tolerability is suboptimal. And one of my favorite studies was done by Dick Menzies and Daphne Yee back in the early 2000s, and they looked at a cohort of patients treated for drug-susceptible TB, and close to 10% of the patients had significant adverse responses to TB treatment that required altering therapy. 5% of their patients were hospitalized, and in people who had these events, the duration of treatment was prolonged by an average of 5 months. So I wouldn't call that well tolerated. So what do we need for treatment of drug-susceptible and or drug-resistant TB from a patient, program, and public health perspective? Well, I think most people would agree shorter duration regimens would be nice. Right now, we're talking about 6 months for most people is the shortest regimen. That's not short. 6 months of taking all these pills is a lifetime for some people. And so ideally, we'd like treatment regimens less than or equal to 4 months in duration for all folks. Shorter regimens maybe could save money for patients in the healthcare system and have the potential to improve adherence. The other issue is we'd like rifamycin-sparing regimens for people who have resistant TB, for people who take companion drugs that preclude the use of rifamycins for treatment shortening, and for people who just don't tolerate them. And then ideally, I do something we could use for isoniazid susceptible or monoresistant TB. And so what's wrong with rifampin? Rifampin is clearly our best current TB drug. The problem is that for some key patient populations, it's not all that great. So for people with HIV and many antiretrovirals that interact, you can't use rifampin with those drugs. People with transplant on immunosuppressants, things like tacrolimus that you just can't use very well. It's very challenging to use that with rifampin. And in the modern era with the opioid crisis, people who have a narcotic addiction who require methadone replacement, you can't use rifampin, you cause withdrawal. And this slide shows the results of a modeling study that was done by Emily Kendall and colleagues, mostly at Hopkins some time ago. And what I would draw your attention to is this, what this slide is showing is the fraction of total mortality, and this is kind of in an India-like setting, that could be achieved by different interventions to do different things to how we treat TB. So you can make the treatments more effective than they are now. You can improve the barrier to resistance. You can make them shorter. You can make them easier to take. And I would draw your attention to the blue bars, which basically says that if you optimize regimens just for duration, if you just made treatment shorter, that gets you close to a quarter of the maximum benefit that could be achieved with a novel regimen. So that's a pretty big difference. And if you look at impacts of reducing treatment duration on both annual TB incidence and mortality, it's pretty significant. This is another modeling study, and it shows that just from going from 6 months to 4 months of treatment, you can reduce the annual incidence of TB by about 2% and reduce the mortality by 4%. And as you go down to shorter and shorter regimens, the most extreme being a 2-week regimen, those are big gains in terms of absolute numbers of people, in terms of both incidence and mortality. So treatment shortening is an important step in terms of making TB treatment better. So the study I'm about to discuss is being planned and hopefully conducted in the context of the Tb Trials Consortium. And the Tb Trials Consortium is a multi-center consortium that basically was designed to take up where the U.S. Public Health Service trials left off. So a little history, study 21 was the last U.S. Public Health Service trial for TB, and that was published, I believe, in 1990. And then sort of, as you all remember, public health funding for TB was kind of dropping off then because people decided that TB wasn't important. And then with the surge in TB in sort of late 80s, early 90s, people realized that, hey, TB is actually an important problem. And so CDC responded by funding what became the TB Trials Consortium in the early 90s, and it was formally reorganized as the TB Trials Consortium in 1997. And the mission of the TB Trials Consortium is to conduct programmatically relevant research concerning diagnosis, management, and prevention of TB infection diseases. It's very focused on things that will be practical and things that programs can actually implement. It began as 26 sites in North America, was refunded as 27 sites in the late 90s, early 2000s. Has been a different set of sites for the last decade, and it just recompeted in late 2020, and the new sites are still pending announcement. So the Crest Tv Initiative was actually the result of a retreat. I believe it's been close to 9 years ago now. My hair was not nearly as gray back then. And Crest Tb stands for Combination Regimens Used to Shorten TB Treatment. And the concept was to develop a phase 2 working group to think about trials of novel regimens that could become an engine for phase 3 work and for regimens that could be tested and used to treat patients. We focused on the highest probability to reduce treatment duration for drug-susceptible TB. And we're sort of in that middle phase of development between sort of the early stuff where you're just trying to figure out what doses of medicines you use and whether they might work, and the definitive phase 3 trials. And of course, we focus on the unmet medical need and the potential for public health impact. So I wanted to present this in the context of everything I just said about HIV, because when you're thinking about new drugs for treatment of TB, any treatment regimen involving new drugs is off the bat going to be significantly more expensive than standard 4-drug therapy, which is very cheap on the international market. But I hope that the HIV experience is persuasive in demonstrating that drug costs can and will come down with both time and advocacy, and we've learned that lesson. So really the HIV lesson that translates to TB and translates to this effort is that political will plus public health benefit equals better and more affordable treatments, and that's the goal. And if you look, this is actually a really, really exciting time to be doing research in TB treatment, because for many years, we had nothing. Nobody was putting money into TB drugs. They were putting money into Viagra and things like that. And I think people have realized that, hey, TB is a really important global public health problem, and it merits research. And that has resulted in this wonderful pipeline of drugs in various phases of testing. And so we have a lot of drugs that are going to need to be tested to get us to better treatment regimens. And that's really exciting. And so we're trying to figure out, well, there's a lot of things to be tested, and we don't have time and resources to test all those things. So the focus is on, well, can we learn some lessons from animal models to sort of figure out what might be the best candidates? And if you look here, I've sort of organized, and this is a slide from Kelly Dooley and Eric Nuremberger, that sort of organizes regimens into things that shorten treatment, at least in mice, by more than 3 months based on relapse data, things that bring treatment 2 to 3 months shorter, and then things that shorten treatment by less than 2 months. And you can see on the left-hand column, there's a number of regimens that include bedaquiline, pyrazinamide, and moxifloxacin, some of which are being tested. So this looked pretty promising. And it was important for us to do these studies in the context of all the other work being done in treatment shortening studies for drug-susceptible TB. And so this has become a very active area of research, and there's a number of studies that are being done looking at various combinations of drugs to try to shorten treatment for drug-susceptible TB. And the durations of regimens that are being tested generally vary from about 2 to 4 months. 2 months is pretty bold considering the setting we have here. So this is a listing of some of the studies that are being done. And of course, Joe just mentioned in the previous talk, TBTC Study 31, which has been publicly presented, but not yet published, although hopefully that's coming soon, that did demonstrate the first treatment shortening regimen in decades. So this is very exciting. I think it's easier, though, with all these listing studies to conceptualize them like this. So if you look at the studies that are being done, some studies are focusing on dose optimization, primarily of the rifamycins. And you all may know the history that when rifampin was being developed, the reason we use a 600 milligram dose is basically because it was expensive at the time. People did big studies and they said, well, 450 milligrams looks worse than 600, and 750 doesn't look much better than 600, so let's use 600. And of course, that's not how we develop drugs today. And people have realized that 600 milligrams of rifampin is on the lower end of the dose response curve. So there's a whole slew of studies that are focusing on dose optimizing the rifamycins, including Study 31 and some of the other ones listed here. Then there are studies that focus on repurposing old drugs, drugs that are already on the market for other indications, to see how they might be used in the context of TB treatment. And the big drugs there are clofazimine, linezolid, and the fluoroquinolones. So there's a bunch of studies looking at that. And then finally, you have studies that are exploring newer drugs that are either are not on the market yet or have recently come on the market primarily for drug-resistant TB, like bedaquiline and protomidid. And you can see where we fall in the Crest TB effort is the combination of repurposing old drugs and exploring some of these newer drugs. So we felt, after review of the data and the brief slide I just showed you, the most promising currently available backbone for treatment shortening is a combination of bedaquiline, pyrazinamide, and moxifloxacin. I'm going to show you some mouse data to illustrate why we settled on that. There's both human and mouse data suggesting that this backbone is quite potent. And you know, this is a regimen that people have taken regimens containing these drugs. We're probably talking in the hundreds of people, and it's got a reasonable safety profile, well tolerated, and it's also compatible with dolutegravir-based antiretroviral therapy. We did not consider a number of drugs that I've mentioned before for various reasons, partially because they're already being tested by other groups. Some of them, so for example, linezolid, we had little excitement for that because it's, for the duration you need to use, it's fairly toxic. And so for a number of reasons, we focused on this bedaquiline, pyrazinamide, moxifloxacin core. And this is some of the mouse data to illustrate why. So this is a treatment of mice. So they infect the mice and then they treat them. In the left-hand slide, you can see this is the number of colonies you can see in the mouse lung after a month of treatment. And I would focus your attention on kind of the right-hand part of the graph here, which is regimens that are based on bedaquiline. In particular, this very potent regimen here that included bedaquiline, rifapentine, and pyrazinamide. And I would note you can use rifapentine with bedaquiline in the mice because it doesn't have the same interaction as people. And if you look at, so the drugs get the colony counts down pretty well. And then if you look at the right-hand slide, you'll notice that the relapse rates after treatment for that 3-drug regimen containing bedaquiline and pyrazinamide, after stopping treatment at a month, they had relapse rates that were quite low. So this was promising. Other mouse models really show that bedaquiline and pyrazinamide is the most potent combination of drugs. And if you look at the left-hand column here, the combination of bedaquiline and pyrazinamide got the colony counts to, in the lung log scale, to 1.6 logs after a month of treatment. Whereas if rifampin pyrazinamide, which is our current quote most potent combination, it was 5.4 logs after a month, so quite potent. And then looking at the right-hand slide, you can see that pretty much all the bedaquiline, pyrazinamide combination regimens really got the colony counts down much more than standard treatment, which you would see that's the RHCD. So this looked really the most promising in the mouse models. And if you look at, again, for relapse data for the specific bedaquiline, moxifloxacin, pyrazinamide core, what you can see is even compared to basically the study 31 regimen core, which was just presented briefly, the relapse rate after treatment for 2 months was significantly lower with the bedaquiline, moxifloxacin, pyrazinamide core. So for the left-hand slide, you see only 33% of the mice relapsed after 2 months of treatment with bedaquiline, moxi, and pyrazinamide versus 100% with rifapentine, moxi, and pyrazinamide. So this appears significantly more potent than current regimens. And a different mouse model, again, you can see compared to standard therapy, which is the 2-RHC, 3-RH in the top column, the relapse rates with bedaquiline, moxi, and pyrazinamide were lower. So this looks, at least in the mice, like a very promising regimen. If you look at the human data, what you can see here, so this is an extended EBA study, which was just looking at the first 2 weeks on therapy. And you see the bedaquiline on its own, which is the top curve, doesn't get the colony counts down very quickly. It starts to kick in kind of late. Whereas if you add other drugs in there, so if you add it to, for example, pratominid, which is PA24, you get a lot more activity. So it's pretty clear that bedaquiline alone is not going to do it. But when you start adding on some of these other drugs, including moxi and pyrazinamide, you probably are going to get a very nice killing of the organism effect. And then if you look at human results of the TB Alliance study 005, the key thing here, so this was both for drug susceptible and drug resistant disease and looking at 8-week culture conversion. And they compared bedaquiline plus PA24, pratominid, plus pyrazinamide to standard therapy. If you had MDR, they added in moxifloxacin. And the point is here, so this is for that BMZ core. If you look at culture conversion rates in the red box here, so very, very high culture conversion rates compared to the standard controls. So after 2 months, about half the people on standard therapy had converted their sputum cultures, whereas in the folks who were even MDR, but pyrazinamide susceptible, is 96% had converted in liquid media and 100 in solid media. So seemed apparently, at least in 2-month culture conversion, quite a potent regimen in people also. There have been concerns about bedaquiline for drug susceptible TB, a lot of which have centered around safety. And I think that the initial concern that there was one of the early studies demonstrated an increase in mortality with bedaquiline as compared to comparator regimens. When that data was looked at more closely, the increased mortality was probably a statistical fluke, because if you look at the nature of those deaths, a lot of them were car accidents or alcohol poisoning or trauma or things of that ilk. Subsequent data, this is a WHO meta-analysis. If you look at bedaquiline versus control across different kinds of patient populations, it's pretty clear that bedaquiline is associated with a reduction in mortality when you're talking about treating multi-drug resistant TB. So the safety data has gotten better. And one of the big concerns, especially in the US setting of treating with bedaquiline, is the potential for QT prolongation. And the essence here is that there's pretty good data now on QT prolongation with bedaquiline, and it's pretty small effects. And even in combination with moxifloxacin, the effect appears very minimally increased. So probably pretty safe, even from that perspective. So we decided that this core would have a high likelihood of being sufficient to reduce treatment to 4 months or less. And we thought that adding a fourth drug was important, both to protect against emergence of resistance and to help get the colony counts down a little faster. And we were looking for fourth drugs that had the highest likelihood of shortening treatment, and that potentially could be used in patients with drug-resistant TB or patients who could not receive a rifamycin. So, you look at that core and you'll notice that, bedaquiline, moxi, pyrazinamide, just that alone, there's no isoniazid, there's no rifampin there. So in theory, this could be an MDR regimen as well. And we had the idea that we could pick some drugs that seemed most active but also keep an eye on that pipeline, and novel fourth drugs could be introduced as they became available. So the design elements for Crest, we wanted to have a standard control arm. And this is very important to be able to calibrate with existing clinical trials. And we're going to start with a three-arm regimen, including standard treatment and 2 new regimens. But the idea is to have an adaptive design so we can plug in new arms as relevant new drugs become available. And one of the design innovations here is we're implementing what's called a phase 2C design. And just to talk a little bit more about that, there's different types of phase 2 trials in tuberculosis. So phase 2A, these are pilot trials to evaluate efficacy and safety in selected populations. And this is really early bactericidal or extended early bactericidal studies. So you're treating for 7 to 14 days just to see how your combination of drugs, or sometimes single drug, get the bacterial burden down. Phase 2B is kind of the next step up. These are well-controlled trials to evaluate efficacy and safety. And in TB, historically, these have been 8-week studies. So you treat with whatever you're going to treat with for 8 weeks, and you look at usually culture conversion at 2 months. And so a number of prior studies, including many Tb Trials Consortium studies, were done this way. Phase 2C is a novel design, and the idea is you treat with a promising new regimen focusing on shorter course in 1 or more arms, plus a standard control. The microbiology is important, and looking at culture conversion is important, but we also follow patients for failure and relapse. So everybody just gets the regimen they're going to get, the new regimen, and then we follow them. And this failure relapse endpoint is crucial because you can get an idea after doing relatively smaller studies of how likely your new regimen is going to be successful if you studied in a larger study. So just to put that graphically, so phase 2A studies, it's a relatively small number of patients for a relatively short time, so about 2 weeks. Phase 2B is more patients studied for about 8 weeks. And phase 2C is probably about the same number of patients as phase 2B, but we're just following them for a longer time, usually for about a year after treatment starts. And what you get out of this, it's kind of, this is the sort of stop, caution, go. It's like our stoplight of TB trials, because what you get out of this is you get at the end of your phase 2C study, in addition to the standard microbiologic outcomes of it, this regimen converted cultures better than standard therapy, you get an assessment of how well did it work? What were the relapse, failure, death rates? Was that all better? And you can get a probabilistic assessment of how likely a new regimen is going to be. So in this schema, which was published by Patrick Phillips, who's one of our key team members, if you say, well, there's less than a 50-50 chance that the new regimen you studied is going to be better than whatever benchmark it is used for unfavorable, you say, we're not going to develop that anymore. That's not likely to be a good regimen. If it's 50 to 75%, you say, you know, we're not there yet. Let's tweak it. 75% to 95% chance, you say, well, okay, maybe we could go and move forward with phase 3. And if there's a 95% chance or higher that your new regimen is going to be effective in phase 3, then that's a go. So this provides less resources. It provides you the ability to do these studies quicker and get an answer quicker and optimize use of resources for the bigger studies that you need. So here's our schema of the Crest TV study. So there's 3 arms. One adds rifabutin to bedaquiline, pyrazinamide, moxie, and rifabutin was chosen because the drug-drug interaction with bedaquiline is acceptable. And that arm was chosen because we thought, you know, adding rifabutin onto this, it's not rifamycin sparing, but that might be the one that we could actually get down to even shorter than 4 months, because those are 2 very potent drugs added together. The second experimental arm adds delamitid onto the BZM core. Why delamitid? Well, it seems to be safe, well tolerated. It helps to get the bacterial burden down, and it would be a nice hedge against resistance. And then standard arm is the third arm. But again, the importance is you see that BZM X arrow at the bottom. The idea is that we could add on other regimens in the future. So we're trying to not just develop a study, we're trying to develop an engine for efficiently testing potential treatment shortening regimens. So we're going to start with these arms, and basically we're trying to develop this thing that has a shell and a filling. So the shell is this design that I've described, this phase 2C design, and the filling is the specific drug regimen. And it takes a lot of work to design the shell, but once you design the shell, you can use it with any filling. And this enables a pretty efficient adaptive design to add new arms with new drugs as things look promising. So the shell elements include who we're going to include and exclude, the safety monitoring, which safety monitoring is crucial here when you're talking about these new regimens, our endpoints, and statistical analysis. The filling elements include drug dosing and schedule, additional safety endpoints based on the specific toxicities of specific drugs. So for example, QT prolongation when you're talking about bedaquiline, and additional inclusion and exclusion criteria based on the specific drug interactions and concerns with special populations. So the engine might look something like this. So you start with this initial 3-arm study, and you get your standard therapy, and you get 2 arms. And it turns out that arm A didn't look so hot, so we don't proceed with that. Arm B looked pretty good, so we might take that to a phase 3. But while we're doing the original 3-arm study, we're developing the next 2 arms with new exciting drugs, so that by the time we're into the analysis phase of the original study, hopefully we'd start enrolling for the next part. And this hopefully will speed things up, because I think everyone on this webinar knows time is lives in tuberculosis, and the longer we wait for more effective regimens, the more people are dying unnecessarily. So our primary objectives, we're looking at time to culture conversion as our primary endpoint in liquid medium, and of course safety and tolerability of each experimental regimen to the control. A lot of safety and efficacy endpoints, and all-cause discontinuation is one of these. It doesn't really help to have a new regimen that microbiologically works great if nobody can take it. So toxicity is one issue, but some people just won't tolerate these regimens, and we thought that was really important. And then there's that phase 2 endpoint, which is a combination, or phase 2C rather endpoint, which is a combination of failure, relapse, and death. And again, this gives us the best clue as far as whether a regimen would be effective if taken forward to phase 3 and if taken forward potentially to treat patients. Our study population, we're looking for people on the sicker end of the spectrum, so smear or gene expert positive pulmonary TB. We will include people with HIV if they can take dolutegravir-based regimens, and we're starting with adults, so there's a lot of discussion about adolescents. We probably will go down to age 12. This is going to be randomized, stratified by whether or not people have a cavity and geography, because it's been shown in prior studies that culture conversion in African sites is a little bit lower than non-African sites. This is 7 out of 7 directly observed therapy, or at least 7 out of 7 therapy. The DOT is probably going to be 5 days a week. And again, following to a minimum of 52 weeks post-enrollment. And one key thing here is bedaquiline, it has a very long half-life. And so we wanted to maximize the follow-up, because there is the theoretical idea that you could treat people with a drug like that and their relapses might be delayed because the drug stays in your body for a longer time. So what we're doing is we're going to follow everybody to a minimum of 52 weeks after enrollment, but people recruited earlier, we're going to follow them until the last participant gets that 52 weeks. So we're kind of getting extra time of follow-up without having to prolong the study at all. So it's a nice efficiency there. In terms of sample size concerns, we're looking for faster culture conversion. In the ballpark here, we're talking about 90 people per arm. So it's a medium-sized study, and it's about the same size as many other phase 2 studies, but again, a little more efficiency because of that phase 2C endpoint. How does this move us forward? Well, hopefully I persuaded you that we're going to try to provide potential alternative treatment shortening regimens here, which is a key step in moving us forward in terms of world TB control. There's also the potential for rifamycin sparing regimens, in particular that delaminid-based arm, so that people who are resistant to tuberculosis or to rifampin, who have intolerance to rifampin, or who are on other medicines that preclude use of rifampin, are not forced to receive prolonged toxic treatment. And this is really important I have to say, in my personal practice, I certainly do see MDR TB, but I more often see multi-drug intolerant TB, in which patients have to take these really long regimens because they cannot tolerate rifampin or rifamycins. So this has the potential for providing alternatives somewhat similar to the HIV world for people who can't tolerate some of the drugs. And again, other consortia like TB Alliance are looking at the same core combined with pretomanid, and we'll be able to directly compare our results with delamanid to pretomanid, and that'll provide some additional insight into the relative contribution of pretomanid versus delamanid to the backbone, and provides an alternative regimen if pretomanid tolerability or availability are issues. So we're hoping this will be something to really move the field forward. Bottom line, this is a really exciting time to be doing TB research. And I have to say today, it was very exciting for me to be able to talk about something besides COVID, which has chewed up a lot of our time and mental energy for the last year. I think it's a great time to be doing this work, and it's a great time to be in TB control, because I think we have very exciting things on the horizon. And just to make this happen, we need efficient, high quality studies to develop shorter, better tolerated, and more effective regimens. So just a thank you to members of our team. This has been a large and ever-changing team of folks who are just an amazing group of people, and I've been privileged to work with them. My co-chair, Kelly Dooley at Hopkins, is honestly one of the most amazing people I have ever worked with. And if you look down this list of people, it's kind of the who's who of people who do domestic and global TB. So it's been such a privilege. I will stop there, and I'm not sure if we're doing questions now or at the end.
Thank you so much, Dr. Stout. You did leave a good amount of time for questions, so I guess you could see that as great or dangerous. So I don't actually see too many coming in right now, but I'll ask one first, and then maybe some of the panelists want to ask a few questions as well. I'm just wondering about the timeline of this, and whether there are now new barriers to getting the study recruiting with COVID. I know at many institutions, non-COVID work is just sort of going to the bottom of the pile.
Right. Yeah, that's a really important question. So we've had a lot of considerations, a lot of discussion about recruiting for TB studies in the age of COVID. The time frame of when this will all start, so I think we're settling out what the new sites will be in the Tb Trials Consortium, and there are some regulatory barriers that need to be addressed, but we're hoping it's going to be this calendar year that this starts. In terms of TB COVID, this is actually being worked out in a lot of places, and if you think about it, most of the recruitment for this is going to take place in, as was mentioned earlier, places that right now don't have much access to COVID vaccines because it's the developing world. Hopefully that will change dramatically in the near future, but it's certainly complicated recruitment. But the truth is that, you know, work is continuing in the age of COVID. And I think that this is one of those things that we are learning to adapt to in terms of our strategies, and just basic things like how to keep both our study coordinators and our patients safe, and how to deal with COVID events have been big challenges for us.
Are there other questions from the panel? I think you can just unmute and ask.
Hi, this is Joe. Jason, that was really great. I think we all learned a lot from that. This is so exciting that we are going to continue to have shorter and better regimens. One question when I think about this, doing this trial and enrolling patients into this trial is it's not easy for us to get a susceptibility result for bedaquiline. I think we can send a specimen out to Denver maybe, but anyway, it's not routine. Same for rifabutin. Our first line midget doesn't test for quinolones. You know, how easy will that be in the clinical trial setting? And then do you think that programs will be able to adapt to that quickly if we need it?
Right. Yeah, so that's a really important question. And I think part of it is, so we're enrolling folks with drug-susceptible TB, meaning that, we're talking isoniazid and rifampin and pyrazinamide susceptible. Rifampin's a pretty good surrogate for rifabutin, so I don't have concerns there. And I think that the susceptibility for bedaquiline, delamitid, that's not going to be done real time. We will get that done. But I think in the setting of enrolling people with drug-susceptible TB, honestly, the likelihood of encountering resistance to the quinolones or any of those other drugs is very, very low. So I think that's part of it. But we certainly will be doing susceptibility testing on the back end for all those drugs.
There's another question actually in the chat box. I don't know if you can see it, but will CRUSH be implemented by TBTC with bedaquiline in a regimen costing about $30,000 per treatment course? What will it take to make this kind of regimen available to low-income countries as well as our own, uninsured US patients?
Right.
Sounds like a tough one.
Yeah, it's actually not as tough as you'd think. Because I deal with this. I mean, every time we talk about the $26,000 for 6 months, as a TB controller, it makes my hair stand on end. But I think the important thing here, that's why I presented all that information about HIV, because for example, in the US setting, bedacoline's $26,000 for 6 months. But the current international price for bedaquiline from the Global Drug Repository is not that. I think it's in the order of maybe 5,000. And I think the key thing about all these drugs is that, when you're talking about developing regimens, no matter what drug we chose, anything new is going to be expensive because of the way drugs are developed and drug companies trying to get their costs back. But I think what we've learned over time, especially with the HIV example, is that these drugs don't stay expensive forever. And with a combination of use and the key thing, advocacy, and I have to really thank our colleagues in the Treatment Action Group and other groups that have lobbied over time for reductions in costs for HIV drugs, but also for TB drugs. So rifapentine is a great example in which lobbying by the Treatment Action Group and its subsidiaries reduced the cost of that overnight by 50%. So I think that the costs will come down. It's that old saying, if you build it, they will come. And I think if we can show that a regimen is effective, then we can advocate and get those costs down to a point where TB programs in both developed and developing countries will be able to afford it.
Great. Any other questions from the panel? I see a few more coming in through the Q&A.
I have one more. Jason, you gave a nice explanation there, the difference between a 2C and a phase 3 study. And the obvious advantage of a 2C is you can have a much smaller sample size. Is the reason that you need to do a phase 3 trial after a 2C is you just need more numbers to give the statistical power to prove your point? What is the reason to go from 2C to phase 3? Why do you even have to do it after that?
Right, because a phase 2C, it's sort of like the difference between the appetizer and the full meal. Because the 2C, it gives you a taste, it gives you a probabilistic taste of how likely whatever regimen it is you're setting will do on the outcome that you care about, which is failure, death, relapse. But it doesn't give you anywhere near the certainty that a phase 3 does of saying, yes, this regimen will be better than the control. What it says is this regimen has a pretty reasonable likelihood of being better than what we think is a reasonable cut point for those events. So it's really, you're getting a hint from phase 2C, but it is not the definitive study design. Let's see, I see some questions in the question box. So One is that does the shorter 4 months treatment regimen for TB lead to a future relapse compared to a longer treatment regimen? That's exactly what we're trying to ascertain, because what we want is a 4 months treatment regimen whose relapse rates is not significantly different than a longer treatment regimen. So we want to treat for shorter with the same or better outcomes. So that's the goal of this kind of study. There has interestingly been some debate in the past about using a shorter regimen that maybe is a little worse, and for program purposes, maybe that would overall be better. That's an ongoing debate, but that's not what we're talking about here. We're talking about developing shorter regimens that are at least as good, if not better than the standard. Another question is 8 weeks the count of days, or is it the start from 1 month to the next? It's a count of days. So yeah, the standard is 40 doses, and it's that same kind of count. So it's yeah, 8 weeks, so 40 during the week doses, with the assumption that people are taking doses on the weekends. And the last question I see is, as far as case studies on new regimen, how long will it take for implementation? That's a really good question. I think it depends on two things. So if we did this study, so the first thing is what are the steps here? So if we do this study, we find 1 or 2 regimens that at 4 months are at least as good as current treatment for 6 months, at least from the preliminary data, then you have to do, as we mentioned, that phase 3 study to confirm that definitively. Once you do that phase 3 study, then you get into the implementation phase. And the implementation phase very much is going to depend on programs, and will depend on that advocacy and trying to cut the costs of the drugs and promote availability of those drugs. And that's going to be very important. And considering I've seen data in medicine that says that new interventions take about a decade from the time that the definitive studies are published until the intervention is implemented, I think we will need to do better than that. And if I have time, there's just one more question popped up.
Go ahead.
About, yeah, on the carcinogenic contaminants and rifamycins and how that would be addressed. Yeah, that's a big issue on people's minds. In my very personal opinion, I think all that is a tempest in a teapot. If you look at the absolute risks of the nitrosamines and exposure in rifamycins compared to eating smoked fish over 70 years, it's tiny theoretical increases in risk. In theory, these are things that could be dealt with through changes in manufacturing, but I think there's a lot of thought being put into that. But my very personal opinion is, I think in the end that's not going to be a major barrier. At least I hope it's not.
Right. Thank you so much. I think actually Dr. Pandita had a question. She can, why don't you go ahead and unmute and ask? I think it's a really important point.
Oh, sure. I just wasn't sure if we ran out of time, but I guess my question was, is there any plans to expand this to extrapulmonary TB cases where the duration is particularly bothersome and it's much more difficult compared to the pulmonary cases at some point, I guess?
Yeah. That's a fantastic question. And I think the short answer is not in the immediate future. And the reason is, as you said, the thing is with pulmonary TB is we have pretty decent ways to follow people in terms of you can collect sputum from them and monitor how they do and assess for relapse. I mean, you know from your experience and your wonderful talk that monitoring extrapulmonary TB microbiologically is near impossible. And for relapse is also very challenging. So I'm going to be interested to see how this plays out, because ideally, yeah, I mean, right now people are often treating POTS disease for 9 months. I don't know that we need to be doing that. And if we had a more potent regimen, that would be very attractive. And so I think that's a really important question, but right now it's very up in the air.
Thank you.
Dr. Berzinski, I see your hand up. Maybe that's
sorry, that was from a previous question. I just didn't put it down.
Okay. Well, this was great. I think we all have learned so much, and perhaps we now have more questions. We are going to take a break, a little bit of a shorter one. So please come back at 3 o'clock for Dr. Pai's presentation. Okay, well, welcome back, everybody. It was a short break. I hope you got a stretch and a coffee. Up next, I'm pleased to welcome Dr. Madhu Pai. Dr. Pai is a Canada Research Chair in Translational Epidemiology and Global Health in the Department of Epidemiology, Biostatistics, and Occupational Health at McGill University. He's also an Associate Director of the McGill International TB Center and the creator of the McGill Summer Institute in Infectious Diseases and Global Health. His research is focused on using translational epidemiology and implementation science to enhance tuberculosis care and control so that products, knowledge, and policies can translate into saved lives and ultimately impact the population the most. So welcome, Dr. Pai.
Thank you, Amy, and thank you to all the organizers for the opportunity. I hope you can see my slides. I have no conflicts of interest to disclose. So I think it's fair to begin with the bigger picture here, and I think this cartoon really hits me hard every time I look at it or present it at any conference. This is a Canadian cartoonist, Graham McKay, who drew this cartoon first, and then I asked him to modify it, which he did. I think the tsunami of COVID is far from over, and I think we have a long way to go before we get out of that. But then all the disruptions it has done, as we saw from Joe's presentation, of disruption of routine TB services, HIV services, basic contraception, maternal and child health, that healthcare disruption will create another new wave of untreated TB, untreated cancer, delayed heart disease diagnosis, so on and so forth. And then the tsunami behind that is the economic recession that we are now living through, biggest recession since World War II, according to estimates. And this is particularly relevant for TB, I would argue, given that 200 million people are expected to be pushed into extreme poverty, which by definition is earning less than $2 a day. And that is the group that is highly vulnerable to TB. So any increase in poverty globally cannot be a good thing for TB is what we need to be worried about. And then, of course, if we survive these tsunamis, there's obviously climate change that is not going anywhere. And it's something that we as humanity would need to worry about. So within the second tsunami of healthcare disruption is how I see TB today. I think it's fair, given that COVID is not going to go away quickly, even if we somehow miraculously vaccinate large numbers of people globally, given the strains and the variants that we've already seen. I think it will take a long time before COVID gets under control. And until that time, we probably should see TB and COVID as a deadly syndemic, both being respiratory infections, both causing similar symptoms that can be confusing for patients and provider alike. Both can elicit a lot of stigma, and the joint effects of the infections, of co-infection between the two, kind of like HIV and TB that we know very well, is something for us to really worry about and actively mitigate. The other thing that I've been writing a lot about is that in the early days, we used to say that, well, TB services are best equipped to deal with another respiratory pathogen. Therefore, we know a lot about contact investigation. We have the gene expert machines. Therefore, we will help with controlling COVID. But now, given the incredible amount of investments and innovations that have happened in the COVID space, we should think the reverse as well. We should ask, what can we steal in a good way, steal from COVID innovations and systems that we can repurpose to reimagine TB services. So we saw the last year's global TB report had already shown us by the midpoint for 6 months, a very worrisome trend of the notifications just completely collapsing. We saw the same in New York City. Clearly, this is not because TB has disappeared. TB cannot disappear this quickly, will not disappear this quickly. It's the fact that people are not seeking care, not able to get care, and not getting diagnosed, certainly not getting reported or notified. And I was wondering when these collapsing notification curves will start trending upwards. And I was sad to see, yesterday, day before, the Stop TB Partnerships report, a brief, that in the last year, we have lost 12 years of progress in the global fight against TB. I mean, that is gut-wrenching. 1 year, 2020 alone, was enough to wipe out so much hard work that the TB community had put in for well over a decade. And the data brief essentially used this data to make the point as to why this is the case. So for example, if you look at the high TB burden countries, on average, they have lost in the year 2020 something like 25% of the notification that they should have normally seen. And that translates to well over 1 million people that we have failed to diagnose and treat adequately during last year alone. So if you compute all of that, that is what they mean by the point that we have gone back to the numbers that we last had in 2008. And contrary to expectations that somehow after the lockdowns, everything is going to jump back to normal, there is a persistent long tail of disruptions in healthcare services and suppressions in notifications. This is data from India, which shows you that there is some recovery, obviously, but it is nowhere close to the levels that we had seen pre-lockdowns. And why is that? For example, India had a huge collapse in the number of COVID cases by December, and now India is on a second wave. Same thing happened in South Africa. Everywhere you find that when you say people are getting back to normal, recovering from COVID, boom, another wave comes along and again disrupts care, results in further lockdowns, further restrictions of people's ability to seek care. So, and this kind of, release lock cycles will show up in our TB notification data. So we cannot at all be comfortable and confident that the levels will return to pre-COVID levels of notification anytime very soon, unless the vaccination rates reach extreme high levels or herd immunity levels are reached, which I seriously doubt will happen anytime soon in the highest burden countries. This is a large-scale survey done by more than 10 civil society organizations, including VRTB, that is co-hosting this particular webinar on the impact on the ground, with more than 1,000 participants from all walks of the TB community participating. And this infographic just tells you exactly how disrupted TB services were during 2020. 70% of healthcare workers reported fewer people were coming into TB clinics and facilities. Patients reported that they were not finding clinics open. Private sector clinics were often closed. A lot of people reported that TB personnel, TB resources were diverted away from TB into taking care of COVID or repurposed for COVID. TB wards were converted into COVID isolation wards. Gene experts were used for COVID testing rather than TB testing. So a complete disarray in terms of what has happened on the ground, which in turn shows us why we've lost 12 years of progress in TB during the last 12 months. And it's not just TB care. TB research is very much impacted. This was a question that we were asking Jason on how recruitment can happen during this crisis in the Crest TB trial or any of the TB trials that are happening. I know for a fact that all my TB work in India has been disrupted. I have not gone to India since January of last year, and I don't know when I'll go because I'm not vaccinated yet. So research is absolutely impacted. And I kind of raised the alarm early on last year in April, actually, of what I called a COVIDization of science, that funding agencies are actively increasing the amount of COVID funding, but they're often doing it at the cost of other disease areas or priority areas. They're taking money away from regular open competitions and putting them into specific COVID competitions. And then scientists have really gone where the money is there. I mean, all sorts of people who do not work on infectious diseases, have no idea, what viral infections are suddenly COVID scientists because that's where the money is available, and they've abandoned everything else that they were doing before. And my concern was subsequently validated by any number of analyses showing that disruption of research and diversion of research away from other areas into COVID is a very, very real issue. So getting funded for TB now, I would argue, is a very, very challenging task given the COVIDization of all funding agencies. And that means a delay in research and development. New drugs, new diagnostics are all kind of pushed back. All trials are getting delayed on the ground, recruitment, and really, really worrisome donor cuts to international aid, development assistance, under which TB falls. All of you may have seen that UK aid has already slashed its aid budget, including research. And UK is a key funder of TB. The previous administration in the US cut funding for WHO in the middle of a crisis or a pandemic. And it will be extremely easy now for high-income countries to use pandemic as the excuse to start reneging on their global health obligations, right? It's easy to say we are hurting, our economy is collapsing, and therefore we will cut back on international aid. That would be extremely short-sighted, dangerous, and honestly stupid. Because if you look at the international aid as a proportion of total budget, it's not even a drop in the bucket. So cutting international aid is the dumbest thing we can do as high-income countries. And we need to be able to advocate to our politicians and explain to them why this may look like a nice populist move, but it's actually terrible for global health and global solidarity. So slashes in international aid and its impact on TB is something we should all be worried about and carefully tracking and advocating for. So I have a whole bunch of pieces coming out next week, precisely advocating that we should not cut back on TB funding. If anything, we must increase TB funding because we've fallen behind on every single TB target or goal that we had prior to COVID. So we have a ton of catch-up work to do. When I'm asked to kind of visualize this, I often say that if we were climbing a mountain to end TB, thanks to COVID, that mountain has now become Mount Everest, because that is the amount of additional catch-up work we need to do. Whichever modeling estimate you look at, I mean, WHO estimates that last year alone, we may have lost another 400,000 people because of COVID-related disruptions to TB care. And we're going to see more of this coming in the next few years on how devastating the impact was. So as I mentioned before, what do we do now, right? In the early days of the pandemic, I saw a lot of us saying and writing and genuinely believing that TB had a lot to offer to the fight against COVID. And indeed, as I showed you, many of the TB resources, people, contact tracers, TB controllers, they've all been pulled into COVID work. So that I get, but I really think we need to start asking the opposite question. How do we use COVID innovations to fight and leverage them for tuberculosis? So here, I offer you a few ideas on how we could possibly do that. One is COVID could we use all of the apps and the innovations happening in this area to also start educating people about TB symptoms, how to separate potentially TB symptoms from COVID, what is the nearest place they can go get tested for TB, the way we've done for COVID. Can we use chatbots and call centers to answer questions about TB? Can we use smartphones and apps to increase or supplement contact tracing, kind of like what New York City TB has done in terms of offering more telehealth services as a bridge, given that people are still struggling to seek care. I was just stunned at the millions of people around the world who have downloaded their country's COVID apps. I mean, thousands, millions of people in South Africa, India, have all downloaded their own COVID apps. And it would be a shame not to leverage this kind of resource for also educating risk assessment and contact tracing. In terms of triage, all of us know digital X-rays are the best triage test we have for TB. And next week on World TB Day, WHO will release the updated screening guidelines, where artificial intelligence-based software and algorithms will be approved by WHO as an accompaniment for digital X-rays. And we also have AI-based tools for reading an X-ray to detect COVID or suspected COVID in addition to TB. We have highly ultra-portable, almost literally like handheld camera systems for TB now. We have cough sensor apps already available in the app source, even though the research around that is still waiting to be completed in terms of validation. It'll be so cool if we can use these to detect a TB cough or detect a abnormal TB lung shadow on the X-ray and get people linked into testing. I think all of us know by now, diagnosis is one area where TB is so far behind other areas. And look at the incredible innovation around diagnosis for COVID. Within a matter of 6 months, we've gone all the way from a laboratory-based PCR test to a simple card antigen test for COVID-19, to home-based saliva collection, to vending machines with COVID collection kits, to molecular technologies that can detect COVID within a matter of an hour with great accuracy. Incredible innovation has happened. And why have we not done this level of innovation for TB is what I ask myself. Could we not learn from this, develop an ultra-sensitive rapid antigen test for TB, be it LAM or something else? Could we not come up with an oral swab as a way to detect TB with molecular technologies? And could we not do a better job of using our existing molecular technologies that are WHO approved, such as GeneXpert or MolBio, the Indian company, to test for both COVID and TB at the same time using different cartridges? Can we not do a better job of integrating across multi-disease platforms? And molecular technologies are multi-disease platforms. So here is a study that we are currently doing in Peru, where you can see we have the GeneXpert system, and you can see we have the COVID cartridge, and we have the MTB RIF cartridge, and we are testing the same patient's sputum sample for both diseases at the same time. And just as Joe showed us data, we are detecting people in whom both tests are positive in Peru, which means there is a subset of people out there who will be infected with both TB and COVID, and a rapid molecular assay is the easiest way to detect it. And if we can detect it on the same sample without making the patient run around and collect different samples, that would be brilliant. For example, if both TB and COVID can be detected in an oral sample, I cannot imagine anything easier than that from a patient's perspective. So we need more research of this kind to integrate testing for both TB and COVID, to also to understand what is the joint prevalence of these two infections in someone with a respiratory chest symptoms. That is hard for the provider or the patient to decide whether it's TB or COVID or whether it's something else. Indeed, India, for example, has already announced a bidirectional screening guideline where people with confirmed TB will be tested for COVID. People with COVID should be tested for TB. Whether this is happening in practice or not, I'm not 100% sure at this point, given that healthcare services are still pretty disrupted. But I hope that this kind of work will help us fine-tune what our combined strategy would be for the syndemic of TB and COVID. I think one thing we have learned during 2020, even in my own personal life, is that I really do not want to travel far to see a doctor or a health system. Anything close to home is gold right now, whether it's food being delivered to our homes, medicines being delivered to our home, or if we can get on the phone, or if we can use a telehealth service to get our work done, that makes us all happy. Because getting out of our homes, taking public transit, going 2 hours across the city just to swallow our pills is not going to work for us. Injectables are not going to work anymore. We have to find systems to deliver care as close to the home as possible. And I would argue there are enough and more innovations in this space that TB should be leveraging. We already have video DOT, smart pill boxes. We have, smartphone-based reminders. We have telehealth. We have home-based delivery of medicines, e-pharmacies. Finding a way to integrate these and make them work for TB would be a massive advance. One silver lining out of this crisis would be that we destroy the myth that TB is a disease that requires highly specialized hospitals and TB clinics and pulmonologists and infectious diseases doctors. We should make TB, if clinic nurses in sub-Saharan Africa are delivering antiretroviral treatment without doctors, right? Nurses are doing it. Why can we not decentralize TB care? I'm not talking about drug-resistant TB. I'm talking about just drug-sensitive active pulmonary TB. Why can we not decentralize it at a level that people are happy to receive treatment, where they're less likely to drop out? By making TB into this complicated, difficult problem that requires highly specialized care, we have, I think, made life very hard for patients, and we need to find a way to kind of reset this after COVID. Data, every one of us can now log into our dashboards, whatever it is that you like using. And you can tell, as of this morning, I can tell you how many cases of COVID my city, Montreal, has had. Now, if you ask me, do I know the TB numbers in Montreal or Canada? I will have to refer you to a 2017 report by the Canadian government on TB numbers in my country. 2017 is where Canadians last got an update on our TB numbers. Well, for COVID, I can tell you what happened this morning. This sucks, right? The fact that we have only annual TB reports from WHO sucks. The fact that CDC can only put out a TB report once a year sucks. We have to push back against this absolute ridiculous ways of reporting to ask for better visibility on TB, more geographical identification of hotspots, looking at vulnerability indices. You can even tell how many COVID vaccines were given in New York City yesterday. Why can you not figure out how much TB is there in New York City yesterday? And it's not a limitation of the technology. We've shown through COVID that this is more than feasible and possible. We just simply haven't been bold enough or courageous enough to demand this kind of visibility from TB. So at a minimum, better data and visibility and usage of data is what we should all be advocating for. Because the minute we see data, it is a very powerful motivating force for policymakers and even the public to figure out what to do with the problem. And look at the incredible amount of research on aerosols, behavior change, masking, transmission, the kind of research that TB has lacked for centuries. Right? We still don't know what the hell is happening in terms of TB transmission, right? And incredible bioengineering work, aerosol research has gone into COVID-19. At a minimum, hopefully masking will no longer be considered stigmatizing, right? We are all using masks today, and some of this will percolate into TB, that we start worrying about not just aerosol and infections, but also what behavior change lessons can we learn from COVID that we can apply to tuberculosis. Social safety, I mean, what a lesson it has been for all countries, particularly the United States, where so many people have fallen through the cracks, not getting paid sick leave, not having pay during unemployment. I think every policymaker has learned that you cannot lock down people without giving them an option to earn a wage. And if we can give people sick with COVID paid sick leave, why can we not give paid sick leave for someone with tuberculosis? Maybe at least for the first 2 months until they complete the intensive phase of treatment where they need to be isolated. I think that is a bare minimum we need to demand, that people with TB will have to take care of themselves. They cannot work during that time. They need paid benefits to tide them through that phase. And research, incredible collaborative research. I mean, Solidarity Trial, Recovery Trial, the amount of effort that's put into COVAX partnership. We've shown in a matter of 1 year that we can do incredibly powerful collaborative research and effort if we put our mind to it. And that results in this ridiculously powerful vaccine pipeline. The fact that we now have 6 approved vaccines in various parts of the world is just absolutely mind-blowing. So science works. Science can win if we invest in science, and we can fast track the shit out of anything we chose to if we put our minds to it. And look at the amount of money that has been sunk into COVID R&D. I found this number, 160 billion, through program announcements and grants, more than 50,000 publications and preprints on COVID-19. And already the RNA platform that Moderna and Pfizer are using is already being repurposed to develop a better vaccine for malaria. And this kind of, when I read this, I'm like, oh my God, where is TB? Why can't we repurpose this mRNA platform for a better vaccine than we have today, which is BCG? And all of this to say that with COVID-19, we were very quick to immediately endorse the idea that COVID is not going to go away without a variety of intervention. Some of it is personal, like masking. Some of it is the health system. Some of it is societal, such as sick leave, sick pay, so on and so forth. And the Swiss cheese model that has been used for COVID-19, Jen Furen and I adapted it for TB. And I've shown this to you here. If any of you want this graphic, you will have it on Monday. We are publishing an op-ed where a high resolution version of this will be available to all of you. And here we are trying to highlight that to prevent someone from the MTB bacillus, we need multiple interventions, right? Each layer of the Swiss cheese has holes, which will allow the MTB bacillus to pass through. And with multiple interventions, each may not be perfect, but together we have a very solid program that can prevent people from getting TB and dying of TB. And obviously there are societal interventions that need to happen, tackling social determinants such as poverty, malnutrition, overcrowding. We need a better vaccine than BCG. We need to destigmatize and educate the public so that when they have cough, they know where to go. Early care seeking or nudge interventions, face masks, cough etiquette, systematic screening, preventive therapy for latent TB, early detection of TB, high quality, effective, shorter regimens, patient support, social benefits, mental health support, and managing comorbidities and TB infection control. None of this is new to any of us, right? We just put it in the same framework since everybody was excited about the Swiss cheese model for COVID-19. We felt that TB required or deserved the same level of attention. So if we could go all in or all out for COVID-19, why are we not doing this for TB is the question that we should all be asking. So the first question anybody asks me when I show them that we need multiple interventions to end TB, the first question we get asked is, so where will we get the resources to pull this off? Well, what do I tell you, right? When the Ebola epidemic hit West Africa not too long ago, pretty much nobody gave a damn. The minute Ebola arrived in US and UK, suddenly everything started happening. This Onion headline tells you what people were thinking of, right? An Ebola vaccine is at least 50 white people away. When white people, privileged people, and those of us who are lucky and privileged to live in high-income countries, when diseases arrive at our doorstep, as Ebola did, as COVID-19 did, suddenly we find the money. We find the money, we miraculously get things done, we can push regulatory approvals for vaccine in a matter of days rather than months. And that's exactly what happened with Ebola in West Africa. I found data which shows that once Ebola threatened high-income countries, investment in product development for Ebola increased by 900-fold. If it was only impacting people in West Africa, I promise you that would have never happened. And this is where we are with TB. TB is a disease of Black and brown people predominantly. Even within United States and Canada, it's a disease of brown people, Black people, immigrants, refugees, indigenous people. And it never gets any attention precisely because it does not threaten those who are privileged, those who are white, those who have money, those who have resources. And that is a sad reality that we have to reckon with. And it gets worse when you actually look at the investments being made and you compare them, when you eyeball them. It's the most depressing thing. US alone, and this is a very conservative estimate, US alone has invested $10+ billion in COVID-19 vaccines alone. We're not even talking about drugs, diagnostics, or anything else. $10 billion in less than a year, US alone. And if you add all countries across the world, that's like, I don't know, 100 billion or more spent on COVID-19 vaccines. And how much did we spend on TB vaccine R&D? 100 million. 100 million in an entire year across all countries, all sources, all funders put together. This sucks. And then I see 25 trials on BCG for COVID-19. 25 trials registered and underway for BCG for COVID-19. And how many trials do we have actually happening phase 3 for TB? Well, the phase 3 for the GSK candidate, M72, might begin in 2013, 2014, and might produce a result by 2028, and might be available for people by 2030, by which time we should have ended TB, for God's sakes, right? And we can't even get a candidate into phase 3 for TB. And there's already millions of dollars spent on BCG for COVID-19. I just don't know what to say here. I just don't know. It kind of gets my blood boiling, you know. Just don't give a damn. Just don't give a damn, right? How to break this way of poverty that we can't even get a promising candidate into phase 3. The company just gave up on TB, and it had to be purchased by Gates MRI to even have any chance of this continuing down the pathway. Even though it showed 50% efficacy, which we are gaga over, even 50% efficacy, we will take it in TB because we're that desperate, right? Forget 90% efficacy that we're seeing with COVID-19. So I can only think of one way to get out of this devastating poverty mindset that we are locked into TB. COVID has shown us that money is there. COVID has shown that R&D can happen, that miraculous research and collaboration can happen. Anything is possible, but we've got to grow the pie for TB. If we are left with so little, then we start fighting with each other, right? Oh my God, the people who are advocating for preventive therapy, well, there's no money for preventive therapy. There's no money for MDR. There's only money for this. There's no money for extrapulmonary TB. Or childhood TB is too difficult to treat. I mean, when are we going to stop this infighting and bickering? Because we've not grown the pie. We're left with scraps, and now we have to then decide, oh, we cannot implement all layers of the Swiss cheese model. We'll only treat active drug-sensitive pulmonary TB. Everybody else can go to hell. We cannot think like that anymore, and we got to start dreaming bigger than this for TB. And that's why advocacy is so critical. And I would argue that every one of us working in TB has to have a second job that we do on the side, that we are also advocates for TB. We cannot just do TB science or TB clinical care and not be advocates, because the field desperately needs us to step up and say, this is unacceptable, right? We got to implement all interventions. It cannot be left to chance, and we cannot allow millions of people to die every year just because they're Black and brown. So America, all of you, I'm addressing you now since this is New York City, you have a lot to contribute here. Yes, everybody is happy that under the new Biden administration, America is back on the global stage, re-engaging with WHO, contributing to COVAX. Along the same way, we all have to advocate for the American government to continue to invest more in TB than it has ever done before, because we have a devastating 12-year slide back that we need to address. I need to do the same advocacy in Canada. I need to push the Canadian government to do more for TB. And if you're in UK, that country is absolutely spiraling out of control and doesn't seem to give a damn for anything. And they need to advocate for TB as well, which is why I'm so happy when I was invited to address the US Congress for this congressional briefing next week on Monday. I said yes, because every opportunity we get to talk to our policymakers, we should grab it with all hands and just tell them what we think about what they should be doing and why it really matters for global solidarity that we do not abandon people and countries when they need us the most. And all of you are welcome to join this briefing. There is still time for you to register and participate. So with that, I will end by thanking all of you, the Rutgers Global TB Institute, New York City Department of Health, and New York City TB Control, and I'm happy to take your questions.
Thank you, Dr. Pai. I could feel your passion and your outrage kind of grabbing me through the screen, and I'm sure that the entire audience felt it as well. I think many eyes were opened, and this is a passionate group, no doubt. I think people who care for patients who have tuberculosis are genetically coded to, do the absolute best that they can. Most of the audience members, I think, are currently doing two jobs, taking care of patients with TB, and many deployed to COVID work as well. Can you give some of our audience who perhaps, aren't experts or aren't leaders, who don't have big social media followings, what can we do? What's a simple or not so simple thing that we can all take action on?
All right. So first of all, many of you want my t-shirt, I can tell. You absolutely deserve this t-shirt, okay? So I will send you the template. Just print it, okay? There is no copyright. Just pirate it happily. There is no issue here. So I'll be sure to send it to maybe Kate, if Kate is on the call, VRTB. Just print these t-shirts and hand them out like candies, please. In terms of what can we do, one is, I think it's a spectrum. Advocacy, I've learned over a period of many, many years, is a spectrum. Each of us can do as much as we feel our life circumstances allow us to do. For example, Akriti is a physician. She's busy. She could have just buried this TB in her head as a bad dream and just gone on with her clinical life and be happy and make money. But she's choosing to dedicate her time to advocacy, and that's powerful, right? So each of us can decide how much risk and time and effort we can do. Kate and so many Tenzin, so many people have chosen to give their time to advocacy, and we should obviously nurture them and give them more ammunition, put them as an opening speaker on every single TB event, the way we had Akriti open. That should become like the normalized baseline in TB. No TB meeting, conference, webinar without a TB survivor to kick off the proceedings. That's one simple ask, easy to do, not at all impossible given the online world we live in. Secondly, those of you who can, just write a letter to your local senator, to your congressperson. In my case, my members of parliament. I've learned that they all read what you write because you are their constituent, right? Even if they don't act on what you're doing, they will read it and they're obligated to send you a response. And when enough people write to their elected leaders, things start moving, right? Make calls, call your senator, call your congressperson, leave a message, It takes 1 minute, 2 minutes. When they see these messages, their aides start working on it, right? And when you can, write a short letter to the editor, to your local newspaper, saying that TB is really wreaking havoc here, and people with COVID and TB are dying at a higher rate in New York City. Therefore, New York City needs more vaccines and more prioritization of TB people. So all of this, op-eds, whatever we can do, it all adds up. It cannot be one person's job. It will not be successful if one person did it. It needs to be a team effort. And then we cannot do it only during TB Day, right? We need to keep advocacy going, I think, as much as we can throughout the year. And it's like a relay race, right? I might get tired, I hand off to somebody else, they run it, and then somebody else takes over. And lastly, civil society groups need way more funding and ammunition to become stronger advocates. Unlike HIV, I would argue, the TB community has largely failed to capitalize on the civil society and the patient advocacy. We've treated them as someone who's on the periphery of our work because we medicalized TB into this medical enterprise, right? Doctors, people like us are running the show. While HIV found early on, you step to the side, put HIV, people living with HIV in the middle, and you catch their coattails and the fire that they will light and then blaze a path forward. The minute we see TB survivors more than just allies as leaders and back them in whatever they're doing, we find miraculous things happening because nobody is a more powerful advocate than somebody who's with lived experience, right? When Akriti talks about TB, we all just shut up and listen because what can I tell you about TB that she's not telling you, right? No matter how well I may have a PhD in TB, but a TB survivor has something more than a PhD. They actually know the damn pain of living through a broken spine or whatever it is, right? To me, not capitalizing their passion and raw energy has been one of the biggest failures in TB, and it's not too late to fix it. We've got to potentiate them and get them on board, which is why I've learned this so late in life. And when I did, I made massive changes. I do not have TB courses without TB survivors. I do not have events without them, and I pay them an honorarium. I have learned this like decades after I should have. But now that I've learned it, I'm unwilling to do it any other way.
Dr. Berzinski, you have your hand up.
Thanks, Madhu. That was an unforgettable talk and just brilliant. My phone's lighting up. Everybody's texting me about how great your talk was. So really appreciate it. Question. I'm very interested in the idea from Stop TB that we've gone back 12 years. Is that because of late diagnosis and people with TB not being diagnosed, not starting on treatment, and continuing to spread TB? Is that it, or is there more to it?
It's mostly that. People just did not seek care, or when they did, there's nobody to take care of them, right? Testing rates plummeted. It's not that TB has vanished. How can TB vanish? There's no way, there's no biological force in the planet that can make TB disappear like that. TB is there, but they are not under good care right now. which means that many people we have to first find, all those we missed. On top of it, we have new TB that's coming up. Maybe new TB might go down a little bit because of masking and people sheltering indoors. I'm willing to grant that. I haven't seen data to confirm that. But I'm worried that intra-household transmission of TB may go up because we've all now been locked within small families in small households for months and weeks. And I also worry that pediatric TB, I have a hunch, I had a bad feeling, I don't have data to back it. But can you tell me why pediatric TB cannot go up, given the number of kids who have been out of school during 2020 and them being locked up inside homes with adults who've been coughing away undiagnosed? I cannot think of any biology where pediatric TB will not go up. I cannot even imagine how that outcome will happen, right? Kids have been just in homes with adults coughing away. The transmission has to go up. And I'm just, all of this will become clearer only in the coming months and years. And then the issue that you raised, Joe, with great data is the joint effect of COVID and TB, right? So you showed a very worrisome increased mortality. I saw similar data from South Africa and Western Cape published in CID. People with current TB diagnosis had an adjusted odds ratio of 2.5 for higher COVID mortality, right? If that is the case, then I am not seeing any advocacy in the TB community on prioritizing people with current TB for vaccination, right? And they may be in their 20s or 30s. We still need to prioritize them. Right now, we're using age as a prioritization cutoff, right? That's why I'm not going to get vaccinated anytime soon. I will not meet the age criteria. And the comorbidities I have seen, you have diabetes, you have obesity, you have all those chronic diseases. I don't see TB among the comorbidities that have been prioritized for vaccination, right? So we need more data, but we should probably act on what we already know and not wait for 3 years to collect that data. We should just prioritize people with current TB for vaccination is my hunch.
Thank you. Yeah, I agree.
Akriti, you want to add anything?
Akriti, I don't know if you want to add anything to the conversation here. While you're thinking, there is a question in the Q&A box from Shama, who I don't think I can unmute, but Shama Ahuja at the Bureau of TB Control is saying that, you know, much public health work has been handed over to other entities, NGOs, public hospitals, private consulting firms. What are your thoughts on the long-term impact of these decisions on future public health work? Lots of resources, as you said, have been identified to combat COVID, but how do we keep these resources that will benefit the entire infrastructure, including TB?
I mean, it really makes me nervous. I mean, where are all the millions of vaccination workers going to come from? They will be taken from other programs, is the hunch, right? If India is going to vaccinate 300 million people in a short period of time, they will be stolen from other areas. And that's why TB is getting less and less priority. In fact, the Indian Health Minister even said it. He said, you know, they're all diverting all sorts of workers into COVID programs, which means who's following up on all our patients who need extra care, let alone post-COVID, post-TB mortality, post-TB sequelae. We're not even there yet, right? We're not even getting people through their 6 months of actual TB treatment, and preventive therapy is totally deprioritized, right? I mean, even before COVID, most high burden countries could not care less about preventive therapy. Now, can you imagine them doing contact tracing or preventive therapy in the midst of this nightmare? So we're going to have so much catch-up work to do, which is why I think we need to advocate for TB resources not to be removed from TB, that we need additional resources to fight COVID. In other words, let them hire new workers for COVID vaccination if necessary, but not touch the TB staff that are critical to keep the TB program running.
Can you hear me now?
Yes, go ahead. Yep.
I think my screen froze in between, but I just want to add that, I completely agree with Dr. Pai, and, of course, he speaks from a lot of, years of experience in this field. And, I do feel there is not enough awareness within non-TB community. I mean, I feel like as people in TB, we try to advocate as much as we can. And, I know people who work in TB, in global health sciences in general, they're so passionate about it, but I still feel we haven't gotten to the crux of the problem, which is creating that sense of urgency and the concern in lay areas, like lay people, the people who are not TB invested. And we saw this happening with COVID too in the beginning. People were not super worried. They're like, it's in China. It's not going to come here in the US. But it quickly evolved into a pandemic, and we saw the results of it. I think, creating that sense of urgency with TB, it's always been a little harder just because the nature of the disease, it's so slow and, but how do we do that? I think that's the piece that we need to work on, and advocacy is so crucial. And I did not realize this, I think, until now when I heard Dr. Pai talked about it with so much passion. So yeah, I do feel it. It's very palpable that advocacy is so crucial, and we saw that happen with HIV as well. So yeah, we are as survivors, I can speak for myself. I'm happy to advocate as much as I can. And very thankful for this opportunity today to be here. Did I freeze again? No. I'm still not tech savvy.
Well, there are 215 people listening, so maybe. so if everybody took one action, after listening here today, I think that would be, certainly a start. I think I'm breaking up also. If you look in the chat, I think there was somebody did, Olivia did post the link to the congressional hearing, which Dr. Pai, anybody can listen. And then somebody else mentioned an app for figuring out who your local politicians are that you can reach out to, because of course they will listen to their constituents. Also very, very important. I'm
sorry.
For any other questions?
Sorry, I'm also going to post the link for the congressional, where we're talking about the COVID and the TB aspect. I don't know if it's through the same link or it's different, but I'll just post in the chat box as well.
Sorry, I think my connection is also a little bit unstable at the moment, but I'm going to check one more time in the Q&A and see if we have any other thoughts, questions. This was, just such an amazing end to this afternoon or morning, depending on where you are. I think I'm going to turn it over back to Dr. Berzinski, who might have a few concluding remarks. And I think we still have time for questions if they come up. But I want to say thank you to everybody, all of the speakers, for amazing presentations that are going to make us think for a long time after we log off. And I want to thank the audience as well. I think you have to really give yourself a huge congratulations for all the work that you've done and accomplished despite COVID and everything else this year. So, and thank you for letting me be a part of it.
I just posted my Forbes piece on the chat box on how we should leverage COVID innovations to fight TB. But the piece with the Swiss cheese model for TB will be out on Monday. I will be sure to send it to Anita and Olivia and have them disseminate with everyone. Thank you.
Well, thanks.
Thank you.
Thanks everybody for participating in World TB Day 2021. Thanks to our colleagues at the Global TB Institute at Rutgers and the lineup of great speakers. I completely agree. Every single one of these, we need a patient advocate like Dr. Pandita to just really bring it home how important it is for us to listen to our patients, to understand them, to hear from their perspective, to really try to understand what patient-centered care is. It's so important to hear it from somebody who's gone through it. And thank you to Jason, Dr. Jason Stout. The work at the Tuberculosis Trials Consortium is so important. Finding newer, better, safer, shorter regimens are really important. And I think your message is true. A lot of those drugs might be expensive today, but we can use the model that the HIV community has used and find a way to bring the drugs cost down once we know that we have a new regimen that's really going to work. And Dr. Madhu Pai, of course, we've been waiting for circumstances popped up in the last couple of years. We've been waiting for 3 years and it was well worth it. We really thank you for joining us today. I know people are going to be talking about your talk for a long time, and I think it really inspired us to continue with our work and to think about ways to advocate for the TB community. So thank you also for everybody who helped me prepare my talk, Erica, LV, Farah, Shayla. We have a great team here at the Bureau of TB Control in New York City. And so thank all of you and our epidemiologists who gave us that great data. It's brilliant. They do great work, and I'm really proud of our team.
Thanks, Dr. Berzinski. And I'm just going to share a couple closing slides with a few reminders as we finish out here as well. So just a reminder, I just sent a chat link in the box, excuse me, an evaluation link in the chat box, which you can use to provide any feedback and request CME and CNE credits as well. Also, just an invitation to join the Coalition for a TB-Free New York City. They meet quarterly on Friday afternoons. We've included the contact information at the bottom here, but I will also include that in the follow-up email that we'll be sending out this afternoon. Just wanted to highlight some World TB Day resources as well as some upcoming events. I know some of them have been mentioned on the call today. I will also include all of these in the follow-up evaluations. I know there are a lot of information and different events shared, so we'll make sure to include all of that for you. And just wanted to give a shout out to We Are TB, such a great group of TB survivors who do a lot of treatment support, advocacy. You can visit wearetb.com for more information. If you're interested in getting involved, a We Are TB volunteer will reach back out to you. So definitely recommend checking them out. And just wanted to say thank you again to all our really wonderful speakers. Thank you to Dr. Patchawala for moderating. Thanks to everyone for joining today, whether it's morning or afternoon for you. I hope everyone has a really safe weekend, and please don't hesitate to reach out to us if you have any sort of questions. Thanks so much.
Bye, everyone. Thank you.
Thank you. Thank you.
Bye.
Bye.